Welcome back. Today we're going to continue and finish up our look at the musculoskeletal system by examining the bones and the joints, how they function and how they're arranged. Basically, the skeleton, which is the supporting structure of our body and the attachment for all our muscles, is divided into two different kinds of structure and function. We look at a skeleton, and if you look at the first slide, in this picture, both front and back, the blue area represents what's called axial bones. The axial bones are lined up vertically for support. They parallel the center of gravity, and they are there basically to hang on the appendages. If you look at the parts that are not colored in blue, this represents what's called the appendicular bones, which is mainly limbs and some girdles, and they attach to the axial system. Now, basically, this is a combination of movement and stability. There are about 206 named bones, many in pairs, and they range in size from this bone, which is one of the biggest, the pelvis, and the sacrum, which tend to be looked at together, an enormous bone, very, very heavy, right down to the one you saw in the middle ear, the stapedius, which is a tiny little bone, just a few millimeters in size, barely weighing a gram. The primary functions of the skeletal system include movement, which we've looked at in conjunction with the muscle attachments, support of the body, and then physical protection of the internal organs. If you look, for example, at the chest as we did, and remember that some of the organs are protected by the chest even though they're in the abdomen. If you remember that the ribs come down this way and this way, cover the liver in its entirety, and covers on this side part of the stomach and the spleen, the bones and the various body cavities tend to overlap. If we go back to the first slide and look how close the lowest part of the rib cage is to the hip bone. If you reach in there on yourself, you'll find only a couple of inches space between your lower ribs on the outside and the top of your hip bone. So between the protection you get from the pelvis, the wings of the ilium right here, and the ribs, there's very little exposure of the internal organs to the outside world. So that's the function of protection. Even possibly more important is the bones is the site of the production of red cells. We have in our bones something called red marrow, which produces red blood cells, white blood cells, platelets, and the macrophages, which I'm going to talk about in the next lecture. We also have a huge, huge mass for mineral storage. We need varying amounts of calcium and magnesium and phosphorus in our system all the time, and what the body does was put them in the bones. Calcium salts and calcium compounds make very firm structures, so the bones turn out to be a reservoir, and we can mobilize calcium out of the bone or put it back in, if you remember parathyroid hormone, and get it into the blood when we need it and as much as we need. There is also storage for lipids, for fats in the long bones, usually in the shaft. If you look at the femur of the shaft, the shaft of the femur, you'll often find fat in there, bright yellow fat. And one of the things that wildlife people do is examine those stores in dead animal populations after a winter to see whether the animals have died because they've starved, lack of fat, or from a predator. If we look at the gross anatomy of the bone, there are several different kinds. Again, coming back to this picture, we have a number of flat bones that tend to parallel the body surfaces. For example, the ilium here, or the surfaces of the calvarium, which is the skull. And these are mostly protective in function. They also have very broad attachments so that the tendons that attach to muscles have a wide spread out attachment for performing their function. The long bones of the body, such as the legs and the arms when we were quadrupeds and walked on all fours, are mostly for weight bearing. They contain both what we call compact bone and spongy bone. So there's a combination of lightness and strength. And they tend always to bear weight along the long axis. You can imagine that this would be important, for example, if you had weight-bearing bones that were oriented this way, it would take much less pressure to snap them than this way. A 4x4 of pine, which isn't a particularly strong wood, when it is held horizontally, can be snapped fairly easily by a small amount of weight. Turned on end, you're talking about 10,000 pounds per square inch. So there's a huge gain in making sure that these bones are always oriented perpendicular to the ground or in the line of gravity. There are short bones which we have, which are mostly made up of little variations of cubes. The short bones tend to be compact on their surface, spongy inside for lightness, and we use them in joints where we need lots of variation in movement in spite of a very strong attachment. And that in our body tends to be the wrist and the ankle. The wrist and the ankle, the wrist bones, there are 8 of them lined up and a similar number in the ankle as well. And these little bones can all move upon themselves in a great many directions and gives us the tremendous variation we have in, for example, moving our wrists. We have a number of irregular bones that have very, very specific functions. For example, we can look at the vertebral column and take out 1 or 2 vertebral bones and see here that this has been designed to protect the spine and to perform functions of cushioning. Here we remember this view of the spinal cord surrounded in bone, providing a cushion, and yet having great flexibility because of its shape and its springiness. Here, very odd group of bones, unlike any other group of bones in the body. We have the facial bones, which are each designed for very specific function, whether it is tremendous pressure exerted by the mandible in chewing, or the lightness you need around the face while providing protection for the eyes. The orbits that surround the eyes give protection. If you put your hand or a finger over your eye, you'll notice that you bump into the top of your brow and the bottom of the cheekbone before you touch your eyeball. This is very purposeful design in evolution. And then we have something called sesamoid bones. These bones are very unique. They are embedded in the tendon and have no ligament attachments. All our bones, if you remember, were held together by ligaments. The ligaments can stretch and move to allow movement, but they provide stability from bone to bone so that we don't have what's called a bony adherence, which wouldn't allow us to move. The sesamoid bones are very specialized, and the 2 that we know of are in both knees, the patella bones. They are in the tendon that runs from the muscles of the thigh across the knee joint and down onto the lower leg. It floats inside the tendon without any ligaments. And the reason for that bone is to act as a pulley or a surface that needs to glide over a very rough and angular joint through a wide range of motion. So that is basically the kinds of bones we have. What we want to look at now before we move on is the bone structure itself. Taking a very typical bone, this one is the femur, as you can tell here from the cartilage, and I'm sorry, the humerus rather. As you can tell here from the elbow cartilage, here's your funny bone, which is called the funny bone. It's an epicondyle, and it's called the funny bone because a nerve runs right behind it under the skin. It's very easy to bang that nerve. It really isn't so funny. Usually sends tingling into your hands. So this is the bone of the upper arm. Here is where it fits into the shoulder socket for rotation. So this obviously is a long bone. First part of the long bone to look at is called the diaphysis, which is this long part of the bone. It's almost always hollow. It means the place through which growth occurs, although not at which growth occurs. Once the bone is laid down on the main part of the diaphysis, that's it. That part of the bone doesn't grow anymore. It is penetrated by a nutrient artery, that goes to the inside, the marrow cavity. And if you look here carefully, you'll see this vessel going up and down and supplying both ends of the bone. Here. Now, the next part above and below the diaphysis is the metaphysis. And the metaphysis is an intermediate area between the diaphysis and what's called the epiphysis. It's where the new growth occurs in young bones, those in our children and teenagers who are still developing longer and longer bones. And above that is the epiphysis. This is called the proximal one because it's nearest the shoulder. Here's the distal epiphysis, which is not shown on cross-section, near the elbow. And this is the end of the bone that supports the articular cartilage. Where a bone articulates is its joint. And we have it covered in cartilage because bone can wear away. If bone rubs on bone, it will wear away. The cartilage is a very dynamic living tissue, and it has a smooth surface that can be replenished. And it allows frictionless movement in the joint. Now the bone is covered, and barely visible here, you see this little flap peeled up with a layer of periosteum. Here we are back to some things like peritoneum and pericardium. It's a smooth, fibrous layer that brings in the nerves and the vessels to the surface of the bone. All bone is covered in this. It's like visceral peritoneum because you can't peel it off the bone very easily. It's adherent. And this is where the pain in bone occurs. When you break a bone, if this, for example, were a fracture, the bone fragments are not the place where the pain comes from. The pain comes from the tearing of the nerves in the periosteum. And in fact, if you want to do bone surgery under local anesthesia, what you really have to anesthetize is the periosteum. You would put your needle in against the bone and inject slowly under the periosteum, and you would then deaden all the nerves. At that point, you could saw through the bone without giving the patient any pain. Problem is, stretching the periosteum hurts too. And so putting the needle in and stretching it with your local anesthetic would make it hurt. Now, the marrow is the cavity inside the bone, and this is the long part of the marrow here. And it has a function at the ends of the two axes of the bone, both down here and up above, to make red marrow, as opposed to the yellow marrow in here. And the red marrow, as I said, is the source of many of our blood elements. The blood supply to the bone is fairly consistent in almost all bones. You do have the nutrient artery coming in the center, and then you generally have an epiphyseal artery which enters at the end of the bone into the epiphyses. And the periosteal artery will nourish both the periosteum and some of the bone underneath. There are a lot of markings on the surface of the bones, and I'm not going to show you a different picture of every one. I'm just going to mention the names. We'll come across them again, and then I'll show you what they are when we need to. There is something called a tuberosity, which we've seen before. It's a roughened, rounded knob that is where usually the tendons attach, and sometimes the ligaments, where the bone has thickened. It hasn't been literally pulled up, but the bone has thickened. And there's something also similar called a tubercle, which is just a smaller knob. We have spines and spinous processes, which we've also seen before, and those are the long, thin blade that comes out the back of a bone. And there are many of them in the body. We also have something called a trochanter, and the trochanter is especially important in the hip bone. Here is the trochanter on the hip. This is what you can feel of your hip bone if you push in through the part of your thigh. Condyles are rounded knobs on the ends of bone. We see that in the knee where the femur joins and rests on top of the lower leg. And an epicondyle is the smaller part of the bone higher up, and you've already seen the epicondyle. This is the right humerus. The patient is facing you, And so this is the side next to the body, and this is called the medial epicondyle. And this is the one I said that a nerve wraps around. There are facets, which are flattened surfaces where two bones join together. And we see these facets here, especially in the vertebral column. So this is the upper facet, which would join the facet of the one above it. And here you can see the junction of the two facets, the upper and the lower. Occasionally, these are where metastases from cancer end up, and you can see on X-ray the destruction of a facet, which is a very good sign that there might be cancerous disease in that facet. Also, occasionally people are missing by birth one of these bones that either join the upper or the lower facet, and that will create instability and allow that spinal part of the spinal column to move off. So we do look for facets. They're involved with a certain amount of pathology. We also have crests. For example, we have the crest of the ilium here, just a ridge that's on top of the bone in question. Sinuses are hollow spaces. We have a meatus, which is a tunnel, a fossa, which is a depression. Remember the posterior fossa of the brain, the temporal fossa, and the base of the skull. We looked at those. And then there can be a foramen or a foramen, which is a hole through which, in the case we looked at, the nerves of the skull exited. The cranial nerves went through different foramina, which is the plural of foramen. And finally, there are fissures, slits, that look like the clefts between two rocks. And usually something goes through there, whether it's a nerve or a vessel. So those are the words you're going to hear us talk about quite a bit. Let's move on and take a look at the embryology and the development of bone. In the next slide, this is the very beginning of the development of the embryologic bone. At this part of development, it's all cartilage. Cartilage is a soft, waxy material that is either the precursor of bone or can be the end of a bone where two bones join. You know, cartilage is in your ribs, where your ribs join your chest. Cartilage is in your knee. Cartilage in almost every bone-to-bone contact. As things develop, we start to get the beginning of what's called a matrix inside the middle of the bone, and hollow areas form. These tend to spread up and down the bone, and we see here now a nutrient artery develops, and we get the separation of real hardened solid bone right here, where the bone is at its toughest, and the end, one end or the other, where we have what's called a matrix. It's a series of molecules that at this point don't have calcium in them. The bone itself does. And as time goes on, we start to get a secondary center of calcification. The primary center is down here. A secondary one forms, fed by this epiphyseal artery. We start getting perichondrium, just like we have periosteum, the lining that's going to nourish this. And eventually, we get a real distinction between the epiphyseal area of the bone, the metaphysis here, and then the diaphysis, or the long shaft of the bone. The other bones all have variations of this pattern. Now, one thing that's very important is that we have something here called the epiphyseal plate. It's the border between the end of the metaphysis here and the beginning of the epiphysis above. It's usually much thinner than this. This is an exaggeration of what it would be in the nearly developed bone. However, this is where growth occurs. This is the place and the only place that growth occurs. It happens off this plate, advancing in an upward direction, laying more and more of this cancellous or trabeculated bone, and then pushing up and making the diaphysis longer. This plate is what we call open in children and teenagers, and it is stimulated by growth hormone. So when the child is growing, a couple of things can happen. If we have an overdose of growth hormone at this point, the child will end up being a giant, or very, very tall, depending on how much growth hormone, but will have normal features. normal proportions other than being very tall, because the growth here is going to be just an exaggeration of what is otherwise normal. If, on the other hand, you have an abnormality in growth hormone that occurs after growth has stopped, after what we call closure of the growth plate or the epiphyseal plate, then no further elongation can occur, but you can lay down bulk into these bones as well as bulk into your muscles. And that's the pituitary adenoma patient we talked about, namely Goliath, the acromegalic giant. Heavy features, heavily bossed eyebrows, frontal bone under the eyebrows, big jaw, heavy tongue, thick hands, thick bones throughout. That's what happens after the growth plate has closed and growth hormone persists. We have another problem for children, and that is that when the children are growing and the growth plate is active, it is, number one, very delicate because it's kind of a shear surface of attachment between two different kinds of tissue. If you injure the growth plate in a child, let's say with a fracture, happens to get unlucky enough to have a fracture go right through the growth plate, especially if it disrupts blood supply, that bone and that bone alone will stop growing. So a child who might injure the growth plate, for example, of a femur, has a really unfortunate situation, and that is that it's going to get asymmetric growth, and one leg would be shorter, one arm, one bone, whatever it happens to be. Very, very serious in children, and it happens to be almost a contradiction because children heal their fractures very, very well. If you look at a child's fracture 6 months after the fracture on x-ray, you won't be able to tell the fracture has taken place. Yet they have this one weak spot, whereas if you injure the growth plate, you have a very serious problem. Let's go on now and look at the embryology, the microscopic anatomy of the growth plates and the bones. First of all, we need to look at the cells. We have several different kinds of cells. We call this the osteoprogenitor cell, and that cell is the determined stem cell of the skeletal system. These are the cells that came down from our pluripotential cells, the basic stem cell, and took a fork in the road that led them to the skeleton. They are now determined, but this cell could be a lot of different things in the skeletal system. Some of them go on and become osteoblasts. Blast is an early form, but it also, in this case, refers to the cells that lay down bone tissue. They create new bone. We have another bone cell. Here's a mature bone cell, and this is called an osteocyte, a bone cell. And it sits in a little space inside the hard bone and maintains the bone. And then finally, there's another completely different cell called an osteoclast, and it reabsorbs bone. It destroys bone. Bone is a dynamic tissue. It doesn't seem so because it's very slowly dynamic, but we are constantly laying down new bone and reabsorbing bone, exchanging matrix and calcium and phosphorus. The bones you're wearing today, you were not wearing 30 years ago. They're actually all replaced. Same way as the blood you're carrying today was not the same blood you had 120 days ago. Tissues turn over. The total picture remains the same by and large, but we actually have different cells involved and different structures that have been completely replaced. The other thing about these bones that are interesting is these can be involved or stimulated by certain types of cancer. The osteoblast can be stimulated by certain cancers that spread to a bone, and you can have osteoblastic bone formation in the site of a cancer that spread to the bone. This patient will lay down very, very heavy bone deposition. More commonly, you have an osteoclastic reaction. The osteoclasts are stimulated, and the patient will destroy the bone, and those patients' bones are weak and prone to fracture. We have another material in here, and that material is called collagen. Collagen is a very strong connective tissue. Millimeter by millimeter, or millimeter for millimeter, it is stronger than steel. The tensile strength of collagen for a given diameter is stronger than steel. One of the things that makes our skin so strong. We don't think of skin as being strong, yet surgeons know without even thinking about it, you always ask for a cutting needle for skin and a non-cutting needle for everything else in the body. You need needles that not only have a point, but are sharpened along their edges to be able to penetrate skin. So skin's a very tough structure, and this collagen is the same material that's in the skin. Let's look at the detailed microstructure of the bone for a moment. This is a slice and an artist's rendering of what we would see. And a piece of bone is taken out of this little section, and this is the long and the diaphysis of the cancellous bone, and brought up here and magnified. You have the outer layer here in the periosteum. This is the fibrous, strong, tough layer that you would have to cut through or put your needle in to get underneath the structure and into the bone. We then have another layer that's osteogenic, and it contains those osteoprogenitor cells and the osteoblasts that are going to lay down bone. So what you're doing is you're laying it down concentrically from the outside, just the way you do the rings of a tree. There's no bone being laid down to any significant amount in the center. We have penetration through these hard little canals of both arteries and veins for the vessels. And then when you get into the interior of the bone, we have this spongy or cancellous bone, which is also very strong, but it's also light. You know, if you look at it, you see it looks like you're looking at the girders of a bridge with lots of triangles. Triangles are very strong structures, and by then getting a lot of air in there, we combine this combination of lightness and strength, and we put them together down here or across the whole layer of the bone. Now, way inside in this hard, compact, dense bone, which you would have to cut with a saw or a drill, are little lacunae, which is a little nest, and inside the osteocyte and through little canaliculi or canals, small canals, this cell can reach out and communicate with its environment and with other cells. The lamella configuration here of concentric rings, again, is a very, very strong setup. So that's our bone system. That's how it's made. That's what its structure is. And we talked a little bit about function. Let me talk to you a little bit now about fractures. The most common things that we do to bones, both as prehistoric people and again now in the modern age, is to break them. I want to show you how bones heal first and then tell you a little bit about the kinds of fractures and what we have to do for them. This represents the healing stages of a fracture. Here is the immediate moments after a fracture. This is a long bone because it's easiest to show and compare with what we've seen. Here's that nutrient artery coming in. The bone's been fractured and this has not been displaced very much. Probably, however, the vessels are going to be torn. The amount of force that it takes to break a bone will break vessels too. So we have what's called the hematoma sitting in here, the fracture hematoma. And sometimes doctors actually look for this with their needle, put their needle in there and squirt the anesthetic if they're going to do a fracture reduction under local anesthesia. If you put your anesthetic right in the hematoma, you know you'll get to the periosteum because the periosteum is where the bleeding comes from. The edges of the bone are jagged. The medullary cavity probably may have some blood in it. And this is about 6 or 8 hours, let's say, after a fracture, and the hematoma is stable. If you then look at this again in about 3 weeks, we have something called callus formation. Periosteum is starting to heal. It's still bulging, and it is now laying down scar tissue. Collagen is coming into this area, being laid down to form a nice grid, and you're starting to get the beginnings of some bone formation in the trabecular way, the kind we saw at the end of the bones, because it can't fill it in all at once. Then if you look at about 3 to 4 months, and this is an adult, what's happening is we get some new vessel growth. Injury stimulates the growth of new vessels called angiogenesis or neovascularization, and we start to get some real bony callus here, and this hardness is getting to be very structural at this point. You could probably bear weight on this bone without a problem. Finally, over the next months or years, in the case of adults, and maybe only weeks in children to months, we get remodeling. The combination of osteoclastic activity and osteoblastic activity is balanced out, breaking down bone that is where it shouldn't be, putting down new bone, and instead of this very deformed looking bone, we actually start to heal this in a much more normal way. Periosteum is healed, the vessels are working again, and this bone may actually be thicker than usual as a response to the injury, and it'll be strong. It'll be actually a place you're less likely to break again than another part of the bone. In a child, it would not look like this. In a child, it would look absolutely as if nothing ever happened to this bone. It's an absolute miraculous thing that happens to these children. Now, we have a number of terms you ought to know. We don't set fractures in medicine. They set fractures in the Westerns, but we reduce fractures. What we're doing is reducing the deformity, so all fractures and dislocations are reduced. Dislocations are not relocated. It's basically the reestablishment of normal position and angle in a fractured bone or a dislocation. Dislocation is not a fracture. It's removing one bone at a joint from its socket or its joint. In the knee, they can come off like that. Out of the shoulder, which is a very common dislocation, they'll just rotate out of the capsule, usually tearing structures, ligaments, as it does so. Dislocations may be combined with a fracture, but it's not that common unless it's been massive trauma, like to the hip in a car accident. Because most of the time, the force that's being applied that might be twisting and getting ready to break the bone pulls it out of the socket, and then the force is released. So in ski injuries, one of the early developments was the release of the safety binding. They took slow motion movies at Mount Snow in Vermont and managed to get a couple of people breaking their legs. And what they found was the patient's tibia rotated in the binding, the leg cracked, and then the boot released because the pressure was off the binding. And so there's a lot of force here, and it depends on what other forces are acting, such as those on the boot, to create and release tension. The bones of the face are very, very good at taking up a lot of impact. People who have been hit with one blow to the face that may or may not knock them unconscious, if one or more of the bones of the face are broken, we rarely have a skull fracture, very rarely. Now, if they've had more than one impact, all bets are off. But you can take up enormous force in the face and protect the brain. Again, that skeletal arching and interconnection is a protective mechanism. Fractures is a break. It doesn't mean anything else but a break in the bone. And finally, we have something called internal fixation, which I'll tell you about, but we can take surgical steel material and put it into the bone and hold it in place if there's some reason we think healing is either going to be impaired or we can't prevent movement. There are too many fragments. And that's commonly done in very serious injuries, but it's also not without risk. And then let me finally now go through the different fractures, except to say one more thing about children's fractures. We can tell on X-ray which one, going back, of these 4 stages we have in the healing of a fracture. Any doctor, orthopedic surgeon can look at an X-ray and tell you the approximate age of the fracture. One of the diagnostic signs in child abuse is multiple fractures in varying stages of healing. A parent will bring that child into the emergency room with a broken bone. X-rays will be taken of that bone, and somebody notices that that's not the only fracture. Maybe there are several fresh fractures. The parent says the child fell down the stairs, got numerous fractures. But somebody will pick up, if they have enough X-ray evidence, that there are fractures in multiple stages of healing, meaning other ones, if it occurred weeks ago or months ago or years ago, those would be completely, in a young child, hard to see. These more recent ones will be visible. And that is actually enough evidence to go ahead and call social services or the police. It's part of the diagnosis of child abuse. Just thought you might be interested in that. Let me show you the different kinds of fractures that you can have. And then we'll move on and we'll look at some of the joint problems we can get. Here's a whole potpourri of fractures. Let's start down here with the most common fracture of all. It's called the Cully's fracture, named after Dr. Cully's. It is a fracture that is more common than many of the other fractures put together because when you fall, it is instinctual to put your hand out to stop it. Unless you practice Aikido and learn to roll, you will put your hand out. The whole weight of the body comes down on the wrist, and the weak point is this part of the radius bone, the larger of the two bones near the thumb, and that fracture tends to break and move the bone up and back. So if you look closely here, here's the patient with a Cully's fracture. The fracture is in the radius bone. This one is not badly displaced. Displaced means moved from its normal angle. And usually the treatment of this fracture is merely to put the bone, reduce it to the normal position, and I'll tell you a little bit about casting in a minute. When we move along here, this is called a Pott's fracture. This is an interesting fracture because in a Pott's fracture, the ankle has been rotated and turned as if the patient took, let's say, a bad step off a curb. We're looking from behind. And the ligaments, here you have ligaments that are holding the part of the ankle to the lower bones of the leg. It's actually the ligament that tears the bone off, not the fracture by the injury to the bone itself. The next fracture is one we see a lot in children. We call this a green stick fracture, and it's just as if you've gone into the forest and taken a live tree and broken a limb. Something you shouldn't do, but if you did, that's what it would look like. The fracture doesn't go all the way through the bone, and it is rarely displaced. It merely splinters some of the fibers because it's a very flexible bone. Children have very, very flexible bones. These fractures rarely have to be set at all. They just need to be immobilized, and they can be treated very minimally. And in children, the big problem is overtreatment. So if you do too much to a child's bone, you're probably going to get in trouble. They do very well without us if we just immobilize them for as long as needed. Now, going on to the next fracture, this is an impacted fracture, the definition of which is we've had force that has broken the bone and rammed it together. This kind of fracture is relatively easy to treat because it isn't moving. Usually these splinters hold the bone very well. If there's been significant shortening of the bone by a lot of impaction in distance, then we may actually have to reduce it by pulling it apart. But we prefer in most cases, if there's not either cosmetic or functional loss by the impaction, to just immobilize it until it heals. Usually doesn't require too much repositioning. This is called a comminuted fracture. Comminution means there's multiple fragments. The comminuted fractures are very serious. They're often sharp little pieces of bone. And treatment varies. You can do a closed reduction, an open reduction, sometimes removal or removal of fragments with pinning and hardware appliances. It varies on how much comminution there is. One of the problems here is if you leave lots of loose fragments, they have been deprived of their blood supply in the shattering, and they may be seen eventually when they die by the body as a foreign substance. And sometimes they have to be removed to prevent that. And finally, the boogeyman of all fractures is the open fracture, called by most people a compound fracture, but that's not the correct term. An open fracture means that the bone has been exposed to the outside. Now, the most gross kind of open fracture would be when the bone actually penetrates the skin. The sharp end of the bone comes through the skin and pierces it. It may or may not go back in. It may be sticking through the skin when you find it, or it may slide back in again. Problem with a compound fracture or an open fracture is that these fractures are very dirty. The skin normally has staphylococcal bacteria on it, streptococci, and other dirty elements, as may your clothing, and therefore the bone has been exposed to great infection risk. Infections in bones are terrible problems because they don't heal well. Their blood supply isn't that good. You can get osteomyelitis, which is an infection of the bone, can lead actually to loss of limb. So these have to be very aggressively treated, open surgically, cleaned, all the dead tissue removed, and we have something called a technically open fracture, and that is when the skin is lacerated over a bone that's broken. We don't know at that point how much contact there's been. We treat that as if it's an open fracture. And finally, we have a couple more fractures. One is a pathologic fracture, in which the bone breaks because it's weakened, usually by cancer, invasion by cancer. You'll have a patient who will tell you the diagnosis. As William Osler said, listen to the patient. 2 patients with a broken hip. One says, I was standing on the corner, I tripped on the curb, I fell down on my hip, and I had terrible pain, and I broke my hip. The other patient says, I was standing on the corner, I got terrible pain in my hip, and then I fell down. That's the pathologic fracture. That hip just broke from standing there, from being eaten by the cancer. The pain came first. The other patient probably broke their hip with the impact. And then finally, there's something called the stress fracture, which soldiers get. Marching too long, pounding on the feet, you can get minimal injuries which lead to too much impact and stress on the bone. And these foot fractures are fairly common. Shin splints in the bones of the tibia are little tears in the periosteum that don't open the periosteum but rupture the blood vessels underneath. You get little hematomas or hematomata between the periosteum and the shin bone, the tibia, and that causes pain, and that's from pounding on hard surfaces. Let's take a quick look now at the joint diseases that we can incur. Here is a typical joint called a synovial joint, just to tell you the structures. Here's the bone, here's the cartilage and cartilage surfaces that fit together with a smooth lining. On the outside, we have a fibrous capsule, which attaches to the bone. Inside, we have something called the synovial membrane, thin membrane like the visceral peritoneum. These synovia, or synovial membranes, secrete fluid and lubrication, synovial fluid, that can lubricate these bones. Now, we have 2 kinds of arthritis, which is inflammation of the joint. And these arthritides, which is the plural of arthritis, are very common and a great cause of disability in the elderly and in younger patients as well. There's 2 kinds. One is called osteoarthritis, and the other is rheumatoid arthritis. They have major differences. It would be good to know these. Osteoarthritis is a degenerative joint disease. It's wear and tear on the joint. It comes from being an athlete or growing old or just living long enough. Your joints don't last as long as we might like them to last. Rheumatoid arthritis is an autoimmune disease. It's an inflammatory arthritis, and you become allergic to your own joints. Another autoimmune disease. The osteo affects the articular cartilage, the cartilage I just showed you in the last slide, and the rheumatoid arthritis affects the synovial membrane more. The effect ends up being similar in the 2 kinds of arthritis. The osteoarthritis, you lose cartilage and you expose the bone. So in this particular case, what happens to this patient is this cartilage gets lost. We have bone rubbing upon bone, and we get lots of inflammation, destruction, and more bone being laid down in the form of spurs that rub and that hurt each other. In the rheumatoid arthritis, the patient has an inflammation of the synovial membrane, which gets thicker, lays down fat and scar tissue, and can also immobilize the joint, but by what's called a pannus, or this thickened synovial membrane. You go into this joint, and it's full of membrane clogging up the joint. Osteoarthritis tends to, at first, affect large joints like the knees and the hips, although it can go anywhere. And rheumatoid arthritis affects small joints like the fingers. The plague actually of people who have fine finger movements required for their work. And finally, the osteoarthritis involves both synovial and weight-bearing joints. The rheumatoid arthritis tends to be bilateral and symmetrical. So you tend to have either both knees or both wrists or both sets of fingers involved. Osteoarthritis, far more common, far more widespread, a major cause of monetary expenditure medically in this country, loss of work, loss of quality of life. Rheumatoid arthritis is much less common. However, it is so debilitating and so serious for the patient that their lives can be, in serious cases, really virtually destroyed. And we now have some drugs to fight this that happen to be somewhat dangerous drugs with a great many side effects, but for many of these patients, it's worth the risk. That concludes our very quick look at the bone and joint system. Next time, we're going to move on to an entirely different subject and look at how our body fights foreign invasion.